Hello friends, antepartum hemorrhage, important topic again. There are two main reasons clinically. One is placenta previa and one is abruptio placenta. So let's first see what are the causes of antepartum hemorrhage, what is the definition, and first we will deal with placenta previa and then abruptio. So by definition, antepartum hemorrhage means bleeding from or into the genital tract after 28 weeks of pregnancy till the delivery of the baby, that is birth of the baby. So after 28 weeks, if there is bleeding till the baby delivers, it is called as antepartum hemorrhage. Before 20 weeks, the bleeding is usually indication of process of abortion, either spontaneous or maybe induced. That is why it is not included in antepartum hemorrhage. That is the abortion process. Common causes. Almost 70% of the time, antepartum hemorrhage is related with placental causes. And two important placental causes are these two. 70% of the times. 20% of the times it is undetermined or unexplained, or we can call it as indeterminate. And sometimes it is extraplacental, maybe cervical or vaginal, in the form of if there is any cervical polyp or there is varicosities over the cervix. Because pregnancy there is congestion and these varicosities they get disturbed and they bleed. Can be the presence of CA cervix, that is carcinoma of the cervix, that may lead to bleeding during pregnancy, or any cause and there is local trauma that can also cause bleeding. But mainly we are going to concentrate on these two things. Placenta previa. When the placenta is implanted partially or completely over the lower uterine segment or near to the internal os, that is placenta previa. So usually the placenta gets implanted either to the fundus or to the lateral edges of the uterus, lateral margins or lateral walls, but rarely near the internal os. And we all know that baby has to come out through the internal os. So if the placenta is situated there would be placental separation once the cervix starts dilating, even before the baby gets delivered, and this premature separation of placenta will be the cause of bleeding, which will affect everything, whether the continuation of pregnancy, mode of pregnancy, time of delivery, everything would get affected. What are the risk factors? When this happens, that the placenta, instead of getting implanted on the fundus or on the lateral edges, why it goes down and gets implanted? There are many theories put forth, like dropping down theory, that the ovum, the embryo comes in the uterine cavity, gets dropped down, and then the implantation is at the lower segment or on the os. Or maybe if in cases where the placenta is big, there is large placenta, large surface area covered, so maybe some end of the placenta is encroaching upon the internal os. But the risk factors which makes the patient prone for this placenta previa: prior surgeries, like most commonly cesarean section. At the cesarean section scar, this placental implantation is very common post-operatively. Other operative scars like myomectomy, hysterectomy. So this increases the risk of having placenta previa almost 4 times. Previous uterine curettage, endometritis, increased maternal age, and very importantly increased parity. PIH is disease of primi gravida. Placenta previa is more common in multipari, because maybe probably the previous locations where the placenta was attached, those locations are avoided and placenta is searching for new locations, so it comes down. So multiparity is the one which leads to placenta previa. Placental size increased by any means, or if there is any abnormality, that is subcensurate lobe, vasa previa, where the placenta is abnormal, and at that time placenta is somewhere, the lobe is somewhere, and the vessels are on the os. Smoking was preventive for PIH, but it increases risk of placenta previa, doubles the risk, that is smoking is a risk factor. What are the common degrees of placenta previa? Type 1, it is also called as just low-lying placenta, where the low margin encroaches on the lower segment of the uterus, but it is not reaching up to the os. Type 2 is marginal, where the placenta reaches the margin of the internal os, but it doesn't cover it. Third type is incomplete or partial central. It's not completely central, where placenta covers the internal os, but when the os is closed, when the os start dilating, that time it doesn't cover it. And complete or total or central placenta previa, that is type 4, is the one where the placenta is completely on the os, and once even though the cervix starts, the os starts dilating, placenta is covering it completely. That is the dangerous variety, central or total placenta previa type 4. For clinical purpose, we divide them into mild degrees and major degrees. Type 1 and type 2 anterior are considered as mild, where type 2 posterior, 3 and 4, they are considered as major degrees. They will be the one who will either cause fetal distress. This I am talking about type 2 posterior, because it is posteriorly situated. As the baby starts entering the pelvic cavity, starts engaging, that time the presenting parts starts compressing on this placenta, and during uterine contraction this compression effect is exaggerated and there is hampering of the blood going towards the fetus, and that leads to fetal distress. So that is why type 2 posterior is considered as major degree or dangerous type of placenta previa. Type 3 and 4, for obvious reason, because partially or completely they are covering the internal os. And as the lower segment starts forming or the cervix starts dilating when the patient is in labor, at that particular time, naturally there would be disruption of the placental vessels and bleeding will start, which is quite detrimental to the patient. What are the symptoms? The only important symptom is vaginal bleeding. Pregnant lady with vaginal bleeding, described as painless, sudden, causeless, and maybe recurrent, and it is unrelated to activity. That means the patient is, maybe she's sleeping, she's doing nothing, she's just casually sitting watching TV, and she suddenly finds her in pool of blood, or she suddenly finds that her clothes are soaked in blood. So painless and causeless bleeding, there is no pain at all, unrelated with activity, fresh red in color, these are all signs suggestive of placenta previa. This bleeding can be recurrent, like she may have some bouts which are just mild, some kind of spotting or little more than that, and it stops on its own, gradually it increases. Usually it is at the later age or increased gestational age, because the reason is simple. When the uterine segment starts forming, the lower uterine segment starts forming, the disruption or the separation starts, and depending on the quantity of separation, the bleeding would be decided. Signs, there would be anemia. This anemia is always proportionate to the blood loss. So we can, from her pellar and HBPCV, we can know that this much blood loss was there. It is always visible blood loss, revealed. Per abdomen, the size of the uterus is always proportional with the gestational age. If she is 30 weeks, the uterine height would be 30 weeks. If she is 34 weeks. There can be malpresentation. Many a times, because the placenta is occupying the lower portion, baby have other presentations than cephalic. FHs are usually present. Stallworthy's sign, as I told you, that type 2 posterior placenta, this is classical of type 2 posterior. Slowing of fetal heart take place when you press or when the head is going down in the pelvic cavity, because of the pressure of the presenting part on the posterior placenta, which is at the pelvic cavity, there is decreased or slowing of the fetal heart. As soon as you remove the pressure or you stop pressing the head, the fetal heart recovers promptly. That's the classical sign of type 2 posterior placenta previa, called as Stallworthy's sign. Again, MCQ. Vulval inspection, only inspection to be done. You will see bright red color bleeding. Vaginal examination, it has to be done in OT if necessary. Double setup examination, what we call it as, because we don't know that the cause of bleeding is what. We cannot predict it if we don't have ultrasound report. In that case, the examination is always to be done in OT The principle is in OT everything is ready. If the patient bleeds more or if she needs operative interference, things can be arranged immediately. If we do her examination in labor room and then examination itself causes some more separation, she starts bleeding torrentially, we will have that time, from for shifting the patient from labor room to OT, then informing everyone. In that time, patient will lose maximum blood. So that is why we want to avoid this mishap. We always keep everything ready, and the examination is called as double setup examination to be done in operation theatre, keeping everything ready. Nowadays, because of availability of ultrasound, patient comes with 3, 4, 5, 6, 7 reports of ultrasound, and when these reports are available, we always know placenta situation, which type of placenta previa it is. So the importance of this examination is practically decreasing. But in case if you don't have an ultrasound report, a fresh ultrasound report, you don't know about the placenta, then always remember that the examination is to be performed inside the OT. What are the complications? It affects everyone in all the stages. In pregnancy, if she bleeds, there can be varying degrees of shock, malpresentation, preterm labor, because if she starts bleeding at 32 weeks, we have to go ahead with labor. So preterm labor is very common. During labor, again there can be bleeding, there can be shock. Early rupture of membrane is possible. Because of that, there would be cord prolapse. Cervix dilates slowly. There can be intrapartum hemorrhage. Antepartum, yes, but if she progresses suddenly, intrapartum also. Operative interference can be very high. And again, this patient has very high chance of bleeding in third stage, leading to PPH. Most of the time, when this placenta is on the scars, there can be either placenta accreta, percreta types, or the placenta may get retained, maybe because of this reason. So this is a very likely complication of placenta previa, that adherent placenta. In puerperium, there can be sepsis or subinvolution. In case of the fetus, complications are because preterm, so preterm baby or low birth weight, asphyxia because blood loss, that's why it decreases. But usually in placenta previa, whatever blood loss is there is maternal blood loss. Asphyxia, suddenly there can be IUD because if she lands up in shock, fetal blood circulation will get hampered naturally. Birth injuries because of operative interference, congenital malformations. Now, the whole management of placenta previa is on this basis that we all know placenta is at lower margin. Whenever the disruption is there, bleeding will start. But in this case, we want to take the pregnancy till 37 weeks, till the fetus matures. That is the whole aim. But in between, suppose bleeding starts, then we have to take a decision. So the treatment varies, expectant management and the acute management, which we need to do, active management, whatever we call it as. Now this expectant management is to be done till 37 weeks, in whom the patient is stable, the baby is fine, not in labor, patient is hemodynamically stable. So let's see what are the criteria. The expectant management is McAfee-Johnson's regime. The aim is to continue pregnancy for fetal maturity without compromising the maternal health. This is very important. Mother is our first patient. We want to take the pregnancy till 37 weeks, but not with a compromise of mother's health. If she bleeds, then we are going to stop there. Who are the candidates? Mother in good health status, whose hemoglobin is more than 10 gram%, PCV is more than 30%, duration less than 37 weeks. Because we are taking a risk here, but that risk would be taken only till fetus matures. Once she is 37 weeks, we don't want to take unnecessary risk. Then we want to deliver her either vaginally or cesarean, depending on the obstetric condition. So, mother in good health, stable patient with good hemoglobin, duration less than 37 weeks. There is no active bleeding. This is very important criteria. And fetus is also in good health, which is assured by either ultrasound or by CTG. This management is carried up to 37 weeks. When we are doing this management, the patient has to be always in the hospital. because the bleeding is so torrential that you don't get time till the patient shifts from her house to the hospital. So always whenever expectant management is to be carried out, it has to be in the hospital. She is to be admitted on complete bed rest. Stool softeners are given so that she shouldn't even stress herself during passage of stools. Anemia, if there, it should be corrected depending on the degrees, if required blood transfusion or with hematinics. Antenatal steroids, in case if she has some warning bleeding, then it's better to give steroids and enhance fetal lung maturity, because if next time she bleeds, we may not get a chance to wait. Anti-D, in case patient is Rh negative. Tocolytics, if there are mild uterine contractions. She's not in labor, but if you feel that mild uterine contractions are there, then you may give some tocolytics. Which are the safe tocolytics? Nifedipine or magnesium sulfate. Tocolytics like ritodrine to be avoided, because there would be tachycardia as a side effect of this, and this tachycardia we don't know whether this is because of patient's bleeding or because of the tocolytic effect. So the safest ones are nifedipine or magnesium sulfate, that's what books mention. Cervical encerclage, this is a controversial point, whether it is to be performed as a prophylaxis for the placenta previa patient. The people who are for it, they feel that because of encerclage there would be lower segment formation would be delayed, and thus the disruption would be delayed, and thus the bleeding would be avoided. Some people don't agree with this, so it's a controversial point, but still it is part of MJ regime, that is McAfee-Johnson. Now let's solve this MCQ. The termination of pregnancy in placenta previa is indicated in. The options are active bleeding, active labor, gestational age more than 34 weeks with live fetus, fetal malformation, and unstable lie. Now let's go one by one. We are talking about termination is indicated in. As I have told you, active bleeding, she is actively bleeding, indication for termination. Then we are not going to think about the fetus. Active labor, if she has good uterine contraction, she is in labor, we cannot wait. Labor has to be conducted. Gestational age more than 34 weeks with live fetus. So they have used more than 34 weeks. The fetus is live in good health, but we want to take the pregnancy till 37 weeks. So I don't think so this is an indication for termination of pregnancy. Fetal malformation. If the fetus has some major congenital anomalies like NMKF or any other, then there is no point taking the risk and continuing this pregnancy ahead. So that becomes an indication for termination. Unstable lie, it doesn't really, why should it be an indication? There is no reason. So for me, the answer of this question, there are three indications: active bleeding, active labor, and fetal malformations. In other two conditions, we can still wait. We don't have to terminate the pregnancy till 37 weeks completed. A 32-week pregnant woman presents with mild uterine contraction, and on examination her vitals are stable and placenta previa type 3 is present. The best management is, options are bed rest plus dexamethasone, bed rest plus nifedipine and dexa, bed rest plus sedation, and immediate cesarean section. Now she is 32 weeker, so we want to take her for till 37 weeks. She has just mild uterine contractions, and on examination her vitals are stable, means she is not bleeding at all. Type 3 placenta previa falls in major degree, but she is not bleeding at present, so we can wait. That is the signal. Then she is having 32 weeks and mild uterine contraction, so she is likely to go so tocolytics, that means nifedipine. And if she goes in labor, then there would be problem with fetal maturity. So let's give dexa to enhance the fetal maturity. So the correct option is give all three: bed rest, nifedipine, and dexa. This is how you have to select the best answer possible. Now we'll just discuss in short how we want to manage this placenta previa. So patient in hospital on expectant management till 37 weeks, we want to manage her. If she bleeds and the bleeding is mild, we can still wait and watch. That bleeding is not affecting her pulse rate. There is no hypotension. Bleeding is less than 15%, so we are happy. It is mild bleeding. We are still waiting on. with the aim that we want to continue this pregnancy till 37 weeks. But if she starts bleeding torrentially, that leads to, visibly we can see that she is bleeding actively. One. Second, if there is tachycardia. Third, if there is hypotension. Any of these conditions we decide to terminate. Then termination will depend on type of placenta previa. So friends, when we are managing placenta previa, we have to see to it that depending on the blood loss, blood should be kept ready. If SOS, we should be giving her blood to replace the loss which she has lost. And then deciding on, we had decided that we want to continue the pregnancy till 37 weeks. But in between, if the bleeding starts, then we have to halt over there. If there is active labor, there is active bleeding, in that case, we have to immediately take the decision for labor. Depending on the degree of or type of placenta, if it is type 2 posterior, type 3 and type 4, those are the major degrees, then in that case, we have to go for cesarean section. There is no scope for vaginal delivery. But in case if there is type 1 or type 2 anterior placenta, then we can go ahead with double setup examination. If there is no other contraindication for vaginal delivery in the form of CPD, big baby, previous LACS, if no such reasons are there or fetal distress, then we can go ahead with vaginal examination, look for the pelvis is adequate, and then we can go ahead with vaginal delivery. If there is any associated obstetric indication, then in those placenta previas also we can take the decision of cesarean section. Otherwise, rupture of membrane can be done and labor can be progressed. Keep blood ready in case she bleeds. Such patients are likely to go in for PPH. So we should be vigilant even in third stage. And this is how we manage placenta previa.